Hello and welcome everybody to our first webinar for 2021, presented by Aroa Biosurgery. My name is Brandon Bosquet. I'm the medical science liaison at Aroa, and I am honored and really excited to introduce our guest speaker today, Dr. Gary Ostahowski. Now, before we get into Dr. Ostahowski, I want to give you a little bit of a background on Dr. O. Dr. O is a proud graduate of the University of Michigan, go Blue. And after he completed his training in Michigan, he moved to the Billings, Montana area and has served that community for 40 years. Now, Dr. Ostahowski by training is a family medicine physician, but serving a smaller rural community, his community looked to him for everything medical treatment wise. He had at times had to prepare OBGYN treatments, general surgery. Dr. O is a true jack of all trades and has done it all during his medical career in the areas of Billings and Hardin, Montana. So as part of that, we have Dr. Ostahowski has been the medical director of the St. Vincent's Wound Care Center and has dove into the world of wound healing. So we're glad to get his perspective today on the use of the Endoform technology with the use of negative pressure wound therapy. So Dr. Ostahowski, thank you so much for joining us today. We really look forward to hearing from you. So everyone give a virtual welcome to Dr. Gary Ostahowski.
Thank you for the introduction. Very flattering. So, we're going to today present two cases that spotlight the use of Endoform with negative pressure wound therapy. And I'm sure that someone out there has the question of why would we want to use Endoform with negative pressure wound therapy? And the answer to that is simple, and that is because it decreases the time to closure over negative pressure wound therapy alone. It does that because Endoform is an extracellular matrix scaffold that has intact vascular channels. It is full of growth factors and other molecules that improve wound healing, and it modulates wound proteases to an acceptable level so wounds can heal. The big factor is that it's accessible to clinicians because we do not have to apply to insurance to use this product like a lot of skin substitutes. So the nice thing is when we want to use it, we can use it. So with respect to using it with negative pressure wound therapy, the two are symbiotic. They both work better together than either one does alone. When I use it with negative pressure, I pack the wound base and wound tunnels and undermined areas with Endoform, activate the Endoform with saline, put a contact layer down, either Adaptic or Mepitel 1 to shield the Endoform from the foam of the negative pressure device, and go from there. So the other thing is when we've had Endoform in a wound, we try not to debride the Endoform if we can still see it present. And even sometimes it looks like yellow slough, but it's really Endoform that's left in the wound. So you have to be careful and not take away everything that we've put in it the week before. This is a photo of the Crazy Mountains, and I like to include some of Montana in my talks. Crazy Mountains come up out of the prairie and are very spectacular mountains. I spend a lot of time up there and I love it. So that's our first Montana slide. You can see from this slide that it is comparable or classified as a collagen and priced like a collagen. but it has so much more going for it than most of the collagens on the market, and even more going for it than a lot of the skin subs that we use. Brandon, do you have any comments about the technology of this product?
Yeah, absolutely. A lot of times people tend to kind of pigeonhole Endoform and call it a collagen dressing. But just like you said, Doc, and this graph really illustrates that most of the comparators are type 1 bovine collagen, and that's it. Whereas Endoform has multiple types of collagen, as you can see, types 1, 3, 4, as well as other important proteins and growth factors that allow for not only wound healing, but as you said before, modulation of inflammation, which is a huge factor in the chronicity of wounds. So I think it's really important to understand that Endoform has a lot more than just type 1 collagen. So to pigeonhole it to as just a collagen dressing certainly undersells it. So
this is our first case, and it was a case that I treated at my small clinic in Hardin, Montana, which is 50 miles from Billings. That was the primary care clinic where I worked for 40 years, and I do a half-a-day wound clinic there now. I was consulted to the swing bed unit across the street to see this patient, who is a 79-year-old male that has comorbidities of hypothyroidism, rheumatoid arthritis, polyneuropathy, and post-bladder cancer with a neobladder in place. He had recently been in the hospital for a small bowel obstruction and underwent a wound dehiscence following surgery, followed by a subsequent fascial closure and then transferred to the swing bed unit. He was transferred by the surgeon with wet to dry dressings. And when I saw him that day, the wound was horrendous. It went from almost his pubis to his xiphoid. He was very depressed. He didn't want to look at his wound. He really didn't even want to talk to us. In the wound, there were large PDS retention sutures present. There was a big knot of sutures down in this area. And the wound was large with about 3 centimeters of undermining distally all the way around it. So that day I debrided the wound. I removed the big knots of suture that were present. And it sure looked like a wound that negative pressure wound therapy would help. So we ordered negative pressure. That day we did dress it with Vash-soaked gauze sponges to be changed daily until the negative pressure arrived, which took about 3 or 4 more days before it was actually put on. So this was a week after I first saw him, and he had had the negative pressure on for about 3 days. There were still tunnels in this area, and you can't really see it, but there was another tunnel up here. The undermining was still present, but the wound certainly looks a lot cleaner. It was still a fairly heavy drainage from the wound. So this day, I, after debridement, packed the tunnels and the undermined area with Endoform Natural High Flow. We placed a contact layer of non-adherent Mepitel 1 on the black foam itself, and then started negative pressure wound therapy at 75 millimeters of mercury. I used that because I was not sure about the neobladder underneath, and I didn't want to put too much pressure on it. And it turned out that low pressure worked very well. We're already starting to see some granulation present.
Dr. O, before you move on there, we had a question from our audience. Now, did you find any difficulty with placing the Endoform in the undermining and tunneled areas?
I did not. What I did in this case was I put the Endoform, I cut the Endoform into strips, and I put it into the undermined area in about 3 layers thick. And then I applied saline to it in the wound. And then the Mepitel and the black foam for the negative pressure.
Great, thank you.
So I did see him on week 2 and did a debridement and continued the same therapy. I didn't take a photo that day. This photo is from the 3rd week, and you can see things are healing nicely. The tunnels are healed and the undermining is greatly reduced. We continued the same treatment on the lower half of the wound, but on the upper half, I discontinued the negative pressure and dressed it with just the Endoform high flow plus alginate and a Mepilex border. We were able to get a good seal on the negative pressure.
Dr. O, did you find that you utilized the natural high flow Endoform mainly because of the level of exudate, or do you feel like it was a better use with the negative pressure?
Well, I think both. It works better with negative pressure because it allows the drainage to come through the product more freely. So you don't have pockets of drainage that are wound exudate that's collected underneath. Works very well that way.
Great, thanks.
On week 4, he was seen, and obviously the wound looks a lot different. Turns out his negative pressure wound therapy had stopped working 3 days prior, and he just kind of left it in place and waited until he came in. So the wound was had been drowned in exudate, and we were seeing a lot of inflammation. However, the wound continued to improve itself with only 0.3 centimeters of undermining now. We dressed it again in this similar way with Endoform, and we applied hydrophera blue and held the negative pressure because of the peri-wound erythema. The following week, it looked even better. I was fairly amazed that at 5 weeks, the wound looked this way compared to how it started. There was no undermining at this point, and there was just a small area that was open down in the distal end. So again, we dressed it with Endoform and hydrophera blue and a Mepilex border. 6 weeks, there was a really small area that wasn't healed. Dressed it the same way. The 7th week, we had a real happy camper. This was a guy that was depressed and couldn't even look at the wound. When we undid the bandage, he had this taped onto the distal end of the wound. For Dr. O, smile, and RNAR from I'm patient RC. And he was a pretty happy guy. And then just comparing the initial wound, week 0, week 7, I took another photo a couple weeks later and it was totally healed. So
what an incredible result, Doc. Really, really incredible, especially the complexity. Now, before we move into the next case, how often do you see the kind of the psychological aspect of patients play into the treatment algorithms that you choose? How often do you say, hey, because this patient is so, whether it's depressed or having some type of mental health issues, how often does that play into your treatment algorithms when dealing with complex wounds?
Very often, more often than not, I would say, especially if they're chronic wounds. People have had these wounds and been living with them for months or sometimes years, and they feel like there's no hope, and those of us at wound healing centers realize that we're their last stop.
Do you find that it's necessary to use a contact layer between the Endoform and the hydrophera? So not that now, if we're not using the negative pressure got us where we want it to go. If you move on to the Endoform and hydrophera, do you talk to me a little bit about the necessity of having a contact layer between the Endoform and hydrophera?
Sometimes I do, and sometimes I don't. If I'm using the Endoform more for closure, in other words, I'm utilizing the growth factors and I'm not so much worried about the scaffolding portion of it, I won't use a contact layer. If it comes off, I put more on, put some fresh growth factors in. And if I'm still interested in the scaffolding aspect of it, then I will use a contact layer so that it doesn't come out with the dressing change.
Great. So you just kind of let the wound speak to you, right?
That's right. Yeah. This should be the 9th or 10th wonder of the world. It's about 45 miles from where I live, and it's Bighorn Lake, which is the backwaters of Yellowtail Dam, a 525-foot hydroelectric dam. This lake runs 72 miles with scenery like this the whole way through the northern end of the Bighorn Mountains. And I spend as much time as I can up there. That's
I'm in suburban Philadelphia. I don't see anything like that around here.
Yeah.
Real quick before I move in, Doc, I just got to ask, what kind of fish do you have there? That's a big mama.
That's a big 9-pound walleye that I caught about 3 weeks ago, and the big fish like that, we weigh them and turn them loose. So
Fishing in Montana in January, that's dedication right there, Doc.
the walleye is an excellent eating fish, so it's a flaky white fish. So
There, now you're gonna be hungry, Doc, huh?
Yeah.
Well, now so that now with that in mind, let's chat about our application tips here.
back to reality. Yeah. So this is some tips on applying the Endoform. And so what we do, of course, is clean, debride and clean the wound first. You basically cut it to size to fit the wound. I'm not afraid to overlap it, and many times I overlap it on purpose and put 2 layers of Endoform initially into the wound. Put the contact layer down and put the negative pressure device over that. So when we change the bandage or change the negative pressure, we try to leave the contact layer in place. If it happens to come off, we usually do not debride the Endoform, but we may put more Endoform down.
Wonderful. Doc, before you dive in any further, what kind of clinical judgments or cues are you looking at when you're deciding between utilizing Endoform antimicrobial versus Endoform natural?
Well, obviously, if you think you have a high bacterial load, you want to use the Endoform antimicrobial
Versus the natural.
They both modulate the proteases, but the silver in the antimicrobial is the antibacterial device, basically, and it works really well.
Great. And we had one more question from the audience here. Is the reasoning that you're utilizing kind of the layered approach more to manage your metalloproteases and metalloprotease activity? What's kind of the reasoning behind kind of almost layering a little bit of the product?
Yes, that's exactly. Put a little more Endoform in to start with. Hopefully there's a little bit left when we change the dressing at 3 days or a week or whenever we're going to change it. If we're using negative pressure, obviously we're changing it 2 to 3 times a week. So, but hopefully there's a little bit of Endoform left, because that tells us that the proteases are in balance and not the levels aren't too high, because they would be chewing up the collagen if they were. So.
Great. So obviously with contamination, the antimicrobial is a wonderful choice, but we have another question from the audience. Do you see, from a biofilm perspective, do you see a difference between utilizing the antimicrobial product versus the natural product when you're strictly focusing on biofilm versus larger contamination?
Well, I think conceptually, there should be less biofilm. Applying silver to the wound base, and I think we do see less drainage, probably using the silver. It's a little bit tough though, because a lot of times we're caught in the dilemma of, do we debride or don't we debride? So it's hard to know sometimes how much slough and biofilm is there and how much is Endoform left over. That's something we agonize with almost every dressing change. How much should I debride it? I will tend to debride around the wound edges. and maybe leave the what appears to be slough in the base, unless it's just too too much.
There we go. As, to paraphrase William Shakespeare, to debride or not to debride, right? So,
Right, exactly.
All right. I guess let's move on to the next case, Doc, if you don't mind.
Okay. This was a very difficult case, and we talked about the mental aspects of a case. When you mentioned that, I was thinking about this case as well, because this was a 58-year-old male, T4 paraplegic. He was otherwise healthy, and when we saw him, he was in a nursing home. He'd had a sacral pressure ulcer developed the year prior that had been treated with wound care and eventually flapped in December of 2019. In January of 2020, the entire wound dehisced. And we had this huge wound with exposed sacrum. It doesn't look that big. This is the distal edge of the wound, but there was like 6 centimeters of undermining. I could stick my whole index finger in the wound undermined area all the way around. And the patient felt hopeless. We offered options. He did have osteomyelitis prior to this. I biopsied it on this day. I did bone biopsies, and it grew E. coli, Proteus, and a strep, anaerobic strep. The wound stunk. It had heavy drainage. He'd had negative pressure on it before that. So this day, obviously, we did some debridement. Dressing-wise, today, on this day, we just packed him with Vosh-soaked gauze sponges to be changed daily to try to clean things up. We saw him weekly for several weeks, for a couple of weeks. And then over the next 3 months, he was in the hospital more than he was not. He got septic from the wound twice. He had a urosepsis once. And we didn't really start seeing him regularly until sometime in April. But I thought I'd throw this photo in because this was the initial presentation following the wound dehiscence. This was what it looked like in March. And I believe we did another bone biopsy that day, and it showed MRSA. We again talked to him about hyperbaric oxygen therapy, and he declined. We applied for a skin sub, which was subsequently denied. And on this day, there was still 4.2 centimeters of undermining. Because there was still a lot of drainage and the wound still was a very dirty wound, we thought we would try a Veriflow vac. Sounded like a good idea, but I think it was a little bit too complicated for the nursing home that he was in to be changing it. It did not work out very well. And I think 3 weeks later, we probably stopped that, the Veriflow. We made a mistake on this slide. The undermining actually was still 5 centimeters at this time. And on this day, we did not start Endoform. We started a different collagen under the wound vac. We placed a regular wound vac, had discontinued the Veriflow a couple weeks before that. And I think for 2 or 3 weeks, we put a type 1 collagen under the wound vac. If you remember, the wound con was, I believe, in April. And like I said, that's when I kind of rediscovered Endoform. Frankly, didn't think about using it at this point. This was in June. The wound is getting smaller. The undermining is getting a little bit less. We had started the Endoform natural, I think 2 weeks before this. And we really started seeing some results at this point.
Definitely looks a lot more fresh, a lot more vascular,
Yeah.
a lot more beefy red.
Right.
at this
This was
point,
week.
just a healthier wound in general, right?
This was week 21.
For the duration of
7
his treatment, correct? That wasn't 21 weeks with the
Right.
Endoform, right?
Right.
There we go.
This was week 13 of Endoform, though, and the undermining is now reduced to 2.5 centimeters. The wound is smaller and closing. And I mean, all this time I've been putting the Endoform in the same way that I did on the first case in that undermined area. You know, cut it into strips and put 2 or 3 layers in and wet it down and then put in the contact layer and the black foam. This was, I'd consulted a plastic surgeon a week before this, and he said the wound was beautiful and ready to be flapped. And so this was our last picture of the wound itself. The undermining had reduced to 1.2 centimeters. We had a well-vascularized bed. The drainage was minimal. There was no more exposed bone. The week following this, I think on October 21st, he had a flap. He stayed in the hospital for a week. He went back to the nursing home. Precautions to not put any weight on it at all. This was the initial wound, and this was the healed wound in early December.
Wow. And obviously he's had it for several months, but preceding this. So really, really impressive there.
Everybody was really happy, including the plastic surgeon. Which, he thought the wound had really come along well, and obviously it's healed fairly well. So
that's wonderful. It's really great that you're able to kind of illustrate allowing the wound to heal by secondary intention to full closure with epithelialization, and as well to kind of set the stage for a more reasonable split thickness skin graft or a flap like this. So I think that's really wonderful.
When I consulted the plastic surgeon, he gave the patient the option of letting this finish healing the way we were going.
Right.
The patient said he would rather have another surgery and get it done.
I can't blame him with that. As long as he's had it for, I probably would opt for the same thing. I can't blame him, even with the progress he was making. Now, Doc, we did have a question basically asking kind of the number, the amount of Endoform that you've used during the treatment, which might be difficult. Could you kind of tell us a little bit more about how frequent you're using, and this patient was using Endoform? Was it daily? Was it weekly? How often was Endoform being applied in this wound?
It was applied weekly. One of the problems was some of the wound vac changes were done in the nursing home. About the middle of May, we started hyperbaric oxygen therapy. He finally consented. He said seen enough progress that he felt some hope. And we did 60 hyperbaric oxygen treatments along with this to try to treat the osteomyelitis and as well as give the wound some vascularity. So we did 60 hyperbaric oxygen treatments through May, June, and July. Having done 60, we took a break, and then prior to his surgery, we did another 15. So
now, Doc, what I know you mentioned in the previous case, is there ever a concern with these more deep, complex kind of tunneling, undermining wounds for an element of hypergranulation versus getting to the point where it's flush and we're allowing for epithelialization? Do you see that hypergranulation is ever really a problem when utilizing Endoform?
Very often.
Okay.
Very often we see hypergranulation, and I mean, you just debride it and cauterize it with silver nitrate and proceed onward.
So then once it's kind of cauterized with the silver nitrate, do you see more of an element of epithelialization after that?
Yeah, for sure.
Great.
You may have to debride it, and cauterize it 2 or 3 weeks in a row, but
just because you're getting that hypergranular tissue doesn't necessarily mean that it won't go on to epithelialization and full closure with the Endoform, if that's the route that the clinician team wants to go with. That's great. And then, Doc, would you be able to kind of talk before we kind of wrap up here? Would you be able to talk about the types of clinicians or people that are able to actually apply Endoform? Is it just the physician or healthcare provider? If you didn't want to just wait every week to apply the Endoform, are there other people that can apply
sure. It can be applied by basically anyone. It's the physician has to order the Endoform, but it can be applied by physicians, nurses, even patients at home. if you have a patient that I do have, I use Endoform a lot without negative pressure as well. And many times I'll open a piece in the clinic and I'll give the patient the extra to use at home.
Well, at least it gives some versatility for the patient, their family members, home care. To, if you're not utilizing negative pressure or stop using negative pressure, that you're able to have somebody besides yourself apply the device. So that's really great as well.
Sure. So this is another shot of my lake. This was January 20 last week. So
that's it. Up to date stuff here. I love it.
yeah.
Great. Well, Doc, I mean, two really incredible cases. And we're kind of finished with the clinical side. So I know we're a little bit over time. So anyone that's able to still join us for a few more minutes, Dr. O, if you wanted to dive in a little bit more to kind of the biology behind it and how the two work synergistically, that would be great.
Sure. We'll go through a few slides here. And so like we mentioned earlier, they work really well together because they both help to build granulation tissue in different ways, and the Endoform provides a scaffold for the angiogenesis and the granulation to develop in, and that's maximized by the negative pressure wound therapy. Negative pressure augments the usage of Endoform. One comment is that sometimes we do have to bolster Endoform to the wound bed, and I don't usually suture it in place. I usually, at the most, will steri-strip it, and I usually don't even do that. It seems to stay in place fairly well. But sometimes you do have to have a bolster to keep it in contact with the wound bed because it has to stay in contact. And then you have to do the other things with wound care. You have to manage your exudate and keep your wound moist. And sometimes in a drier wound, you have to put hydrogel down. And as we mentioned at the very beginning, it does reduce time to closure versus negative pressure wound therapy alone. On the average of 1.3 weeks or 18% reduction. This is what the Endoform high flow looks like. Non-hydrated and hydrated. And you can see the porous nature of the product. And sunrise over the Pryor Mountains.
Beautiful, beautiful. We do have one more quick question here. Well, a couple more questions before we finish up. Are you aware with the other collagens that you've had experience with? Do you know if they have any element of an ECM at all, or is it just kind of strictly that type 1 collagen there?
Most of it's just type 1. I don't believe there's much ECM at all.
Yeah, I don't think from my experience there was either. So
collagen in general does modulate protease levels. So even the type 1s, I believe, do to some extent.
Great. And then we have just one more question. We had an audience member that wanted to know more about the practicality of it. I know we saw how it's used and the biology behind it, but how do you find Endoform is just kind of using from a handling standpoint? Is it slippery? Is it tough to kind of handle?
It's like a thick paper, so it's very easy to handle. Once you get it wet, it's a little bit tougher, but because it does get slippery and tend to bunch up. And a lot of times you can use a wet Q-tip to kind of put it on the wound where you want it. So
that's a great tip. That's a great tip. So we have another really good question from an audience member as well. When we were going over the application before on that foot, we noticed that the contact layer, I believe, I don't know if it was an adaptic, was pretty far beyond the edges before the negative pressure was applied. Was that done for any particular reason? Do you have concerns with maceration?
I suspect that was trimmed down before it.
Okay, before that.
I didn't do that case, but I suspect it was trimmed down. You can overlap at a little bit, but that would have made placing the negative pressure fairly difficult the way that one was.
I agree. Yeah, in my experience, you certainly want to kind of cut that contact layer to kind of the wound size to minimize the maceration there. So great question. Yeah, you certainly want to be able to kind of trim that contact layer, not have too much overlap to avoid that element of maceration. So you want it to be kind of cut to size. Really great question from the audience. Any other questions that anyone might have? I think that was a really, really impressive case series there. Feel free to of course, go to endoform.com for some more resources, some more case studies of varying etiology, and of course, follow us on LinkedIn as well for more information. I'm on there too if you wanted to reach out to me for more questions as well. You can find me on LinkedIn. But really, really great information, Doc. We appreciate your time and our audience members' time. If you have any other questions, that'd be great. If not, Dr. O, I mean, you're incredible. I really appreciate your time.
Thanks to everybody for watching. Oh.
Thank you very much. Enjoy the rest of your day or evening, depending on which time zone you're in. And it's been a pleasure. Again, I'm Brandon Bosque from Aroa Biosurgery. And again, Dr. Gary Osterhowski, big thank you. And we appreciate your work.
Sure enough. Thanks.
All right, I'll take care.